My name is Misty Blevins with the National Rural Health Association SC. I want to take this opportunity to welcome each of you to today's webinar, Telemedicine to the Rescue for Rural Hospitals. We are unable to provide CEUs or CPEs for this session. Certificates of attendance will be available upon request for attendees who register, attend the entire webinar, and participate in poll and survey questions. Attendees may use these certificates with third-party organizations or their employer as documentation of having received an hour of webinar instruction. NRHA Partner educational webinars are recorded, and an on-demand link will be sent in 24 hours to all who registered for the live webinar. Please note that throughout the presentation, all participants will be placed on mute. If you need to communicate with the webinar organizer during the session or have a question for the presenter, please use the question box at the bottom of the GoToWebinar control panel. We will answer questions after the webinar. I will now turn the presentation over to Carrie Dostie.
Thank you, Misty. I would also like to personally welcome all of you to AMD Global Telemedicine's educational webinar, focusing on success stories, use case scenarios, and policy updates for rural hospital applications. We hope today's presentations enlighten you with some new ideas for how telemedicine technology can and is changing the way rural hospitals do business and improving patient care at the same time. And so today, I would like to introduce you to our three featured presenters: Gary Capistrant, the Chief Policy Officer at the American Telemedicine Association; Allie Paquette, the Application Analyst, Imaging and Clinical Systems at Baystate Health; and Dr. Maria Lopez, the Associate Vice President for Health Equity and Inclusion at the University of Utah Health Sciences Center and formerly with the Arizona Telemedicine Program. First, Gary is going to give us an update to start off with the current telemedicine policy and updates that are creating opportunities for expanded rural coverage. Gary?
Thank you. Well, I want to talk about basically how we take the best of healthcare and using technology, make it available anywhere, anytime, to anybody. And there are lots of ways that can be done. Obviously, there are some services that are very highly specialized in expertise, that is. You can think of doctors that, a few doctors who may be the only people in the country that deal with a rare disease. Or, to my knowledge, there are only 2 pediatric neuroimmunology labs in the country, one in Dallas, one in Los Angeles, but they can be available to everybody. My colleagues will present a lot of good common examples of that use, and so I won't get into it too much. We do enjoy working in Washington, D.C. with the National Rural Health Association. It's interesting that we will both be in Minneapolis for our conventions in May. We will come to town right after the National Rural Health Association meeting. So look forward to some opportunities to see additional people. A couple of things. One is about telehealth, and I assume that the people that are on this call are ones who may not be as knowledgeable as they would like to be, but it's important to emphasize that telehealth is a tool. It is not a particular service. So there are a couple of common uses of it, like interactive video, much like this presentation. The use of store and forward, think of it as a medical version of an email with a photo attachment. Remote patient monitoring of people with chronic conditions in particular. And then a small but potentially useful use of robotics to provide services, basically remote controlled services like intubations. it does cover a range of services. It's as diverse as healthcare in general is. Basically, every medical specialty can use telehealth for something. Even orthopedic surgeons can use it for pre and post-op and for other kinds of things involved with the patient recovery. For us, we use a very simple, very inclusive definition of telehealth, telemedicine, e-care, mHealth, whole variety of terms that are used, that it's basically a healthcare service received by a patient from a provider who's at another location. It doesn't get into all the technology and all the other things that get in the way. Though it's a range of service, it's important to emphasize that there are some that are much more established than other uses. Like it's very well established with radiology and pathology. We're just starting to get into some uses, emerging uses with telehealth for rehabilitation, for example. So one of the things is that Medicare is often used as an example of coverage for lots of things. Medicare is not a leader in telemedicine coverage. It is one of the most meager payers. We're focused very much on payment innovations as a way to get into the Medicare program, but it's important to understand that in fee-for-service Medicare that there are a number of barriers that come into play. One is the service is rural only, and for some rural providers, they're surprised to find that Medicare considers them metropolitan. So that's an important distinction to know. Also, the patient has to be at a certain kind of site, like a hospital or other designated common health sites, like a doctor's office. And then another barrier is Medicare covers only certain procedure codes, CPT or HCPCS codes, for being done by telehealth. Fortunately, other payers do not have those kind of restrictions for Medicare. For example, the Medicaid plans can do whatever they want on telehealth, and fortunately, 46 plans do better, have better coverage than the Medicare program. Also, in terms of private insurance, one of the measures that we use is what we call parity, which would cover telehealth provided services just as in-person services are covered. And there are 29 states plus the District of Columbia that right now have requirements that the private insurers pay for telehealth just as they do for in-person services. There are other aspects that are important, such as broadband access, and we are heavily involved, as is NRHA, on working with the Federal Communications Commission to keep improving their programs for rural health and other infrastructure improvements. And it's also important that telehealth often takes a network. And so it is important that providers collaborate locally to create a robust network. It's kind of like a farm co-op that if you have 100 families in, that co-op can do certain things, but if you've got 10,000, you can do a whole lot more and have better services and better pricing and other kinds of things. So one of the things is many states have a state telehealth network group, and so to look first of all to see what is available in your state for that, and if your state doesn't have one, to look at organizing it. So there are opportunities to expand Medicare coverage in rural areas. As I mentioned, we're very focused on payment innovations because it's much easier to prove the cost savings argument when Medicare isn't exposed to some of the concerns about fraud and abuse or increased utilization. When the provider or the payer is like a managed care plan, if they're capped in terms of their reimbursement. Good example is Medicare's been loosening up on the telehealth restrictions as it relates to one of the ACO models that they use, Accountable Care Organization models, called Next Generation. and then there are opportunities in fee-for-service. This slide shows some of the specific opportunities that we're looking at. There are two bills that I would like to highlight. These are congressional bills, both in the House side right now. HR 2066, the Telehealth Enhancement Act, and HR 2948, the Medicare Telehealth Parity Act. There is action also underway with Senate Finance Committee right now focused on chronic care that may provide some opportunities to move this forward. And we're waiting for the introduction of a new Senate bill that's a different package than the two that I mentioned, that we're hoping to see introduced yet this month by Senator Schatz, of the U.S. Senator from the state of Hawaii. There are a number of policy resources that are available to you, and a lot of information is available on them. If we can go to the next slide, please. One is our own material from American Telemedicine Association on our main website, americantelemed.org. And then a lot of this information is so fast changing that we do it in a wiki format. So atawiki.org is completely open to the public, and a lot of information, particularly about coverage and reimbursement and other kinds of practice rules are there. I've highlighted two resources from the federal government. These are both under the Health Resources and Services Administration. The first listed there is the site for the Office of Rural Health Policy, and the second is an office within the Office of Rural Health Policy, that is the Office for the Advancement of Telehealth, or as we call it, OAT. There are other resources. For example, OAT funds regional telehealth resource centers. So every state is part of, almost every state is part of some regional telehealth resource center that can be a resource to you, particularly for technical information about getting set up in telehealth. And actually, the Office for the Advancement of Telehealth had recently funded a center specifically on rural telehealth policy. So thank you, and my colleagues will now give you some real good examples of how telehealth or telemedicine is commonly used to improve rural healthcare.
Thank you, Gary. Now, our next presenter, Allie Paquette, is a key component to the successful telemedicine program at Baystate Health. Today, she will share with you how their telemedicine program has connected rural patients with big city specialists, and what medical specialties have worked best for them and why, and how to standardize telemedicine equipment and choices.
Thanks, Gary. All right, so I wanted to start by giving you guys a little background about our hospital. We have our health system, really. We have a primary trauma center with 4 tertiary hospitals, and they range from about 15 to 40 miles away. No, oops, Carrie, it looks like it's switched over. I lost the screen, so we'll keep going here. So our earliest telemedicine initiatives began over 5 years ago, and those were focused around video-to-video for telestroke. But through grant funding, our efforts to expand telemedicine began about 2 years ago, and that's what I want to focus on today. So the scope of this project, we received a grant from the state of Massachusetts, the CHART grant, which stands for the Community Hospital Acceleration, Revitalization, and Transformation. And through that grant, what we were trying to do was utilize telemedicine to provide specialist access to our patients in tertiary locations, so at our smaller hospitals. Our goals were to minimize, the travel time and maximize the efficiency of the physicians themselves to prevent them from having to drive to these various locations. We also want to limit the needs for the patients to travel outside of their communities to come to the main hospital. And through both of these things, we were able to actually get patients access to the specialists sooner than they would have otherwise done. And we are currently in the process of receiving a second phase of this grant. We hope to hear on that soon. And the specific function of this round will be to reduce the number of transfers from our smaller hospitals to the main medical center. So again, we're trying to keep the patients in their local hospitals and improve the patient experience. So next I wanted to talk a little bit about the clinical use cases that we've tried and some of the things that we've learned from that experience. So we've done some telemedicine in neurology, cardiology, speech pathology, psych, geriatrics, and critical care. Neurology was really our front runner because we were dealing with the same physicians that had done telestroke for years. So they were the early adopters of this new clinical telemedicine, and was a really good experience for us just because of their buy-in. In our cardiology experience, we learned from phase 1 of our grant that there were some challenges with the stethoscope audio, which is obviously a vital component for them. So we've used that information, and we're actually upgrading our stethoscopes for the second round to try to allow the cardiologist to be able to do more with telemedicine. One interesting thing I wanted to mention was around psychology. That was one of the areas that we were nervous to try, but it had some of the best patient satisfaction scores. So after the telemetry consults, telemedicine, they did a survey, and the response was really positive on those. So that was an interesting area to try that we didn't expect. With the geriatrics, we've had some trouble due to the patient population. They're older and more confused patients, have had trouble with the audio, but again, this is an area where we're making some enhancements to the speaker setup and providing headphones to the patients to try to improve on that. So moving forward, I want to talk a little bit about the telemedicine equipment and how we made our selections. So what I'm focusing on here and what we've been doing with this grant are telemedicine carts with medical devices. And thankfully, we were able to purchase equipment through the grant to do these consults. There are also just telemedicine consults that are video to video, and that's what we've used with stroke and other use cases. But the carts with the medical equipment are really, really key. And some of the requirements when we were selecting a solution, obviously important was ease of use for the physicians and the telepresenters. So one of our requirements was that we wanted to have the video component of the conference and the medical device video feeds in the same application. So we didn't want to have them opening multiple windows. That was one of our key requirements and something we found really helpful for adoption. And then obviously we needed a secure connection. We wanted everything to be HIPAA compliant for these consoles. So those are some things to keep in mind. And from a technical perspective, we went back and forth between having a wired or a wireless solution for our telemedicine carts. And while wireless is a tempting solution because of the lower cost and the added flexibility, we found that even in our hospitals that have relatively good wireless coverage, that it just wasn't reliable enough for the video bandwidth, and we've had much better success with wired solutions. So we recommend going that route whenever possible. Another angle is the consulting physician and what device they use to perform the telemedicine consult. We do want to try to allow them the flexibility to use their devices of choice, but we found it easier for support purposes to actually provide them with a standard device and have it set up and maintained so we can have some controls in place and help ease their connections. Other considerations are around the clinical workflow. So we found that sometimes the logistics of setting up the consults is more complicated than actually the technical connection between the two. So, whether you're going to do inpatient consults versus outpatient consults, how it's going to be initiated, who from the clinical service is going to perform the consult depending on the time of the day. So we really recommend having a clinical type coordinator for the telemedicine side to work out those details and really try to keep the process smooth for both the patient, obviously the telepresenter, and the physician as well. So don't forget to pay attention to the logistics outside of the telemedicine technology. So as telemedicine continues to grow, this chart grant is only one of the use cases that are coming up through our health systems to use telemedicine. We're concerned that it's going to grow really quickly, and from an IT perspective, we want to standardize and be prepared for this expansion as it comes. So what we've been doing, and through the equipment that we purchased as a part of this grant, is develop standard solutions. So we have a standard cart that we say this is our telemedicine cart with medical devices, and we have a standard solution for our video, just video consults. And so we have this all available to our physicians and staff throughout the hospital, so that when they make a request and we want to expand telemedicine, everything is sort of ready to go. It not only helps them to have budgeting and information available, but it will help us in the support of the equipment. If we had 10 different solutions in-house, it could get out of hand really quickly. So we think the standardization is going to be really important. And the next slide is a little bit of hard to read all the details, but the idea here is just to have a template in place where we can present the clinical users with a simple set of questions about their requirements and get down to the bottom and have information about what type of solution they need and estimated cost. So we'll continue to update this as we expand, but we think this is a good point to be at for our clinical partners who want to start using telemedicine.
Thank you, Allie. Our final presenter today is Dr. Maria Lopez. And she is currently the Associate Vice President of Health Equity and Inclusion at the University of Utah Health Sciences. With her current experience and her past work with the Arizona Telemedicine Program, Dr. Lopez is going to give us some insight into various ways telemedicine is and can be used that you may not have considered. Dr. Lopez?
Thank you. Thank you so much for the introduction, and thanks for all the participants. And of course, a very, very warm thank you to my colleagues and friends at the Arizona Telemedicine Program. You know, we're in a really, really special time right now because telemedicine is really not a foreign concept anymore. Telemedicine is thought about, and it's almost part of just how we do medicine. I'll share with you some different scenarios and opportunities for telemedicine, some of our experience with bundling of services, and some specific experiences with oncology care. Next slide, please. So why is telemedicine so prevalent? Telemedicine is so prevalent because of something that probably each of you have in your pocket. And that is that in the United States, almost everybody owns a cell phone, and 2/3 of folks own a smartphone. So people are using technology that is very familiar to them. You know, when we started, patients would refer to the care as seeing their doctor on TV. Now it's how they do FaceTime. It's how I see my grandchildren, they will say. So people have access to the internet, they are using the internet, and they are using video conferencing type technologies. So they're very familiar. And in some situations, patients are asking clinicians, why don't we do this through telemedicine? But we have to remember that about 15% of folks in the United States still do not have regular access to the internet, or if they have access, do not use it regularly. So this is something for us to think about, where the disparities and differences lie as well. Next slide, please. And here's just an example of how very, very prevalent this is in the general world. And because of this general use, it's something that patients are asking for. Next slide, please. So as clinicians, you know, our bag of, our doctor's bag or our clinician bag that has our tools for healing and for maintaining health is really modified now. And the use of technology, and this, really think about this very broadly, because there's a use of technology that includes computers, but they're all the mobile technologies as well. So, and that's not part of the focus for today, but to really think of telemedicine and telehealth broad as being part of how we do medicine. Next slide, please. And here is really the telemedicine bag, or the doctor's bag of the future. And you see the packet that was put together by the Arizona Telemedicine Program staff, and that has been used in different parts of the country and of the world. So to really think that this is not only a unit that can, can be used at a clinic, but it's also, there are ways to make those technologies portable so they can be used in multiple clinics. And there's the use of wireless technologies. One of the best things about technology, and I am not a technophile, is that technology gets better and cheaper. So it's a wonderful opportunity for translational medicine, for translational research, to work with our engineering partners to come up with diagnostic issues that are related to the use of the technology and to come up with solutions. So these technologies can be very widely implemented, and I suspect will just be used at a greater pace as time passes. Next slide, please. So what are some of these scenarios? What are some of these opportunities? Something that we haven't quite touched upon is the prevalence, and there actually are very, very good data, not only for efficacy. So efficacy data are pretty consistent for telemedicine. As far as can telemedicine be diagnostic, that's, really the studies are, it's either very close, as good as, and on occasion better than. So telemedicine efficacy is pretty much out there. The question of cost is an area that is very closely being looked at, and also appears to be an area of significance. And one area where there is great significance is with the use of tele-ICUs. So here is the ability where you have hospitals, rural hospitals, that may be small hospitals, may have small intensive care units that may not be able to support a full ICU staff. But these hospitals can partner, can be connected through telecommunications technology, and here they're connected to a hub. In some cases, these are university centers, but coordinated healthcare systems linked in, and the intensive care unit staff centrally can really help with the management of these intensive care units that are in smaller hospitals. And this use is not only tremendously clinically effective, tremendously cost effective. There's so much positive response from the patients and from the families. The patients can stay near their loved ones. Their loved ones can be at home and can go visit on a regular basis. So all of those aspects are invaluable for patient healing. In addition, there is the economic benefit to that community, that the local staff is contributing to the, is receiving rather, they're economically connected to their own community, and which helps support the viability of the local hospital. So lots and lots of benefits that are increasingly being looked at for the implementation of telemedicine, and EICU is really one very, very good example of this. Next slide, please. Here's a project that we were involved with digital mammography, and this was in partnership with folks in Tuba City in Arizona. So Tuba City is in northern Arizona, and mammography, is standard of care for breast cancer screening. And the process was difficult because there were either traveling physicians that would come and read memos on a scheduled basis, or there were the images were taken and the films were mailed to the radiologist, and then results were mailed or faxed back. So that was the old process. Now, of course, digital imaging and, as was mentioned by Gary, teleradiology is really, digital images, and it's part of how it's done. But at this time, this was a new approach, and it really revolutionized the whole way that care was delivered. The problem with having someone come or mailing the images, occasionally images would get lost. This way, images never get lost. But also, because of the time delay, there were times where a patient might have a diagnosis, might have an abnormality, and you couldn't find the patient. So with the scenario with digital mammography and with the commitment of the radiology department at the University of Arizona, the patients actually were able to come back and within an hour generally receive their results. So women would come in together, get their mammos, go get coffee, go get lunch, come back, get their results. So what a wonderful way, not only for the technology to be effective, to be diagnostic, but to really help patients get their results in a timely way, help patients get follow-up in a timely way, and really change the way in which that health care was delivered. So this is, I think, another wonderful example of the benefits of telemedicine. Next slide, please. Fetal ultrasound. A very common procedure during pregnancy, but a very scary procedure when you get to level 2 ultrasounds. So ultrasounds where there's a question about the development of the heart, the development of the spinal cord in the fetus. And so at this point, these are generally women who have had some sort of difficulty in the past. There's a lot of anxiety and stress in the data set from the Arizona Telemedicine program. Women would often travel 3 to 4 hours each direction, sometimes be traveling alone without support, and then waiting an hour or two if they were doing this conventionally. Doing it through telemedicine, one of the great ways, and suggest this to you, is if you are doing an imaging study, whether it's ultrasound, echo, to not only have the tech present, but to also have the interpreting clinician present. That way, there's both the result that is given at that time to the patient and his or her family, but there's also the opportunity for the tech to talk with the other tech and for learning and education to take place. So a comment that would often arise from these interactions is that the tech felt that they were better in doing these procedures later. So again, a change in the way healthcare was delivered, where the woman would go to the local hospital or clinic, have the ultrasound, be with family, and be able to receive the results. And people often said, whether good or bad, just to have the results right then was just such an ease of mind. So this is another great example for the use of telemedicine. Next slide, please. And of course, we couldn't talk without talking about telepathology, and although this is very much, in many settings, standard of care, it's some of these efforts and some of the digitizing efforts, were really pioneered at the University of Arizona, and really want to give a shout out to Dr. Ron Weinstein, who's the director of the Arizona Telemedicine program, and really a pioneer, and some would say the father of telepathology. So here was the opportunity. In the past, if you had to have a consultation, a pathology consultation, you'd be mailing those slides. You'd be mailing some slides often. Sometimes slides get broken, they would get lost. but to be able to digitize the entire slide and to make the technology with the work of the engineers, to be able to make this very similar. Here's another really important aspect of telemedicine integration, is to make it as similar as possible to how things are done clinically. So some of the difficulties before were that telepathology attempts were not quite as seamless as they would be as with the use of the microscope. But with a digitized image, the entire slide was sent. The entire slide could be reviewed by the consultant, and there is still the opportunity to magnify up and down, which would allow, again, to have it be very similar to the use of the microscope. So telepathology is another very important aspect, and what I really want to talk about now is, and encourage you to think about, as you think of aspects of telemedicine, are there ways where you could integrate, where you could bundle services? Next slide, please. So as a breast oncologist, and being very concerned about the anxiety, and as I mentioned to you, for many studies, for many exams that a patient would go to, the waiting is the hardest part. And the waiting is difficult because really, and I think if we all think about our experiences as patients, when you go, you have your blood work, you have whatever study you're having done, you worry. And you worry about what might be discovered. So that anxiety, again, is just very, very normal. So the thought in thinking about these different tele services would be, are there ways to integrate? And thinking about the integration of telemammography, telepathology, and teleoncology. Next slide, please. Maybe a little out of order. Or another aspect, rather, where we could integrate services would be in teletrauma. Integration of the direct interaction. Trauma services often engage teleradiology as well. And sometimes, again, think about this. You may not have local expertise in some areas, but you may be able to beam in expertise. So think, again, just encourage you to think of ways to bring in different elements. For example, in diabetes care, you may have a local clinician, but you may not have an endocrinologist. You may have nutritional services, but you may not have a podiatrist. So the opportunity to bring in some of those services from the telemedicine aspect, and even to do them all at one time, almost a one-stop shopping, which would be so helpful for the patient so that they don't have multiple appointments, especially if they are traveling long distances. Another example for bundling of services is pain. Now, what's interesting is pain service, and another thing to think about is, what are the services that you already provide that are by nature interdisciplinary? And pain is one of those. You know, if you have a pain service, you have an anesthesiologist, you have a psychologist, you have a physical therapist, an occupational therapist. So these are all folks that are already working together as a team. You may have a pharmacologist, you may have a mind-body person. So to really think of what are the services you already provide, where you may have elements and where you may be able to bring in some of the other services so that this would all be for the benefit of that patient and his or her care. So pain is a interdisciplinary, and you can bring in the different specialists in a way to bundle those services. Some specific examples in oncology, cancer prevention, and so I really want to just explore with you from prevention to end-of-life care. There can be applications for teleservices in oncology care. Genetic counseling is an area. Genetic counseling has been done by phone. Genetic counseling has been done through video conferencing. and has been shown to be very effective in all of those areas. Has also been very effective in education from both the clinical, so the physician, nurse, the whole healthcare team level, as well as the patient education level. And it's so wonderful when you have, you can bring groups of patients together in different communities, and then they actually can become a virtual community. We've talked about teleradiology, so the use of diagnostic imaging for early detection, the clinical consultation, and think of that so many aspects. For example, you can beam in the CAT scan for the review of the surgeon, who can then discuss those findings with the patient in a surgical oncology consultation. There are even efforts to review planning images at a distance for radiation oncology, so that there could be the local tech, the patient has been seen, has been examined, the plan has been developed, and then this can be reviewed at a distance by the radiation oncologist and implemented. There's a lot of work with survivorship care and with group visits, some of which may be able to be done at a distance, to begin developing this virtual community for survivorship care. So there's a lot of interest in that area. And then in palliation and end-of-life care, there have been some studies with using home health technologies to allow patients to have access to their nurse, to their physician, to their palliative care team at that point in their cancer experience. Clinical trials. Now, we know that patients who are living close to a comprehensive cancer center or to a cancer center are more likely to go on trial. Folks that live at a distance are less likely. A lot of interest in using these technologies to educate patients about clinical trials and to do evaluations and consents at a distance. So we're looking at IRB efforts for consenting and for allowing this improved access to clinical trials at a distance. And then putting all of this together in a tumor board format. So, all patients now are generally discussed in a multidisciplinary fashion to really be sure, you've got the radiation oncologist, you have the surgeon, the medical oncologist, all together, making sure that everyone's on the same page with the cancer plan. So to do this and to support local communities to do this with their patients is not only is critical for patient care, but also very important for education of the local community physicians. And a new concept, which is the whole ECHO model of care, or what we had called the chart review model, which is really, we learn so much from our patients, and to have clinicians come together, connect with an expert clinician, and to review, here's how this patient is with, let's say, with hepatitis C. Here's the management that we're doing. What are your thoughts on that? And to receive that expertise. Again, here's I love the word echo, because it really is this echoing of this knowledge. That the knowledge is being expanded for the benefit of the patient at a distance. So really, lots and lots of opportunities as you just begin to think about it. Telemedicine, teletechnologies are ubiquitous. It's really just up to us to think about how we can best implement them. Thank you so much for your time.
Thank you, Dr. Lopez, for sharing so many possible use case scenarios and creative ways to bundle the services. I think those are definitely helpful and gets people thinking about a lot of possibilities for telemedicine and how they could implement it. So Gary, Allie, and Dr. Lopez touched on so many great points on how to make telemedicine programs successful for rural hospitals and clinics. And we thought, in closing, it would be helpful to just provide you with some considerations to keep in mind when choosing your telemedicine equipment and technology. And as Allie touched on in her presentation, there's a lot of thought that they put into it at Baystate Health regarding different scenarios. Also, of course, the environment of the equipment. You know, does it need to be mobile or move from room to room? Or are you going to set it up and leave it in a dedicated area? Or does it need to be portable and something you can carry with you for house calls? And of course, these considerations will help guide you down the path of the right equipment. Medical specialties you want to service. So what are you looking to provide, not just now and today, but also think about what could help you in the future and what are some of these other use case scenarios or services you could offer. And so considering a technology that is modular so that you can add on later as you need it and only purchase what you need now and then consider adding on things as your needs evolve. And then interoperability of equipment. You know, Allie mentioned having everything for them. It was very important to have everything in a single platform instead of switching applications or switching platforms. And again, that just comes back to ease of use and the buy-in from physicians and telepresenters to want to use the equipment. You want to make it easy. And part of that is having, you know, the interoperability with other medical devices, software platforms. There's so many new things and new technologies popping up. You want to make sure that you can find something that is capable of interfacing well with others, with other software or devices or EHRs or video conferencing equipment. So you want your telemedicine program, you know, you don't want it to be a separate practice of care. It should be something that can be easily streamlined with your existing practices and workflow technology. And then also training, of course. You want something that less is more. So finding a technology that is easy for people to use will make them want to use it more. Some of the types of clinical telemedicine excuse me, equipment that AMD specializes in and specializes also in helping our customers define what products fit their needs, such as a counter management software, which allows the clinicians and remote physicians to conduct real-time exams, or medical devices and equipment, so you can collect that diagnostic information from the patient, and clinical telemedicine systems and carts, the packaging for equipment. So how is it all going to be put together? And now we'll move on to our Q&A session. I've also put up here the contact information for each of the presenters who've graciously agreed for each of you. If you have any questions outside of this, you can contact them. If you have any questions, you can type them into the box in the control panel on the bottom right-hand corner of your screen. Okay, so we do have a couple questions. I'll start with that already came in. The first one I think might be for you, Allie, but if anyone else has anything else you want to add to it. The question was, what do you foresee as the possible barriers to sustainability with the program, and what has been prepared to deal with this? And I think you've touched on that in some of your slides as far as standardization, but I didn't know if you had anything else to add.
Sure. One of, I think, the barriers, and this kind of goes along with Gary's presentation, is just the reimbursement for the providers. Unfortunately, it is one of the questions they ask when we propose telemedicine to them. And so I think that's a potential concern. We are using our grant funding to, try to work in some incentives for the physicians until we can get that insurance coverage and reimbursement up to speed. So that's one of the challenges. And I'd say something else along the technology lines would just be, the various systems that they have to work with, and just they get a little intimidated by the idea of learning a new system, getting training on it. And so I think it goes back to the ease of the use. If you can demonstrate to them how simple it is, that will really help. But I think they're just some of the physicians get intimidated by just the concept of it. So that's the other challenges to get them on board.
Okay, great. Thanks, Allie. Okay, we have another question about how telehealth can affect privacy and increase information misuses. I'm not sure if, Allie, would that be again for you? But how are you controlling the privacy or the misuse of information that people might get using the technology?
Right. So We make sure with our telemedicine solutions that we're using that we have point-to-point network connections so that they're secure. We use VPN connections for any physicians that may be external to our hospital at the time of the consult. And in regards to our just video conferencing solution that is used for some telemedicine, we have a HIPAA-compliant network infrastructure for that video conferencing to be sure that that information is maintained.
Okay, great. Dr. Lopez, how do you foresee the use of clinical telemedicine tools for house calls? I know you went through quite a few different scenarios. Is there any experience with or thoughts on basically taking that doctor's bag and starting to do clinical home visits? Dr. Lopez?
This is Gary. I can jump in a little bit. Yeah, certainly one of the things you can do is take that equipment and go mobile with it. The other is to just do a video to the patient at home. This is commonly done with mental health counseling. You take somebody with severe depression, they're lucky if they get out of bed, much less go into the community to seek care. So there's all kinds of ways to serve people directly at home.
Thank you, Gary. Okay, all right, this is a little bit long question, but bear with me here. It's a critical access hospital launched telewound care in October of 2014, and we've added telepsychiatry for our nursing home residents 2 months ago. One barrier we've encountered is specialist physicians who expect retainer reimbursement from our hospital to be on call for telemedicine consults, which would be a new expense for us, for which we could not be reimbursed. How have other hospitals dealt with this issue? Gary, is that something you have any background on or could comment on?
Well, one of the things is you can often get reimbursed for that when it's done by video. Many payers don't pay when it is telephone only, but if it is basically there's a procedure code that would describe what it is that you've done, like one of the office visit codes, that can be a billable activity. Other times, people will just do things because it's good care, and it's part of what attracts patients to them. For example, we heard about the tele-ICU. That is something that Medicare doesn't pay for. The distant hospitalist doesn't get reimbursed for that care. We're trying to get that covered, but it's the kind of thing that many hospitals have taken on for a whole lot of good reasons, like reducing lengths of stay, reducing complications, but it's also very important for patients. So reimbursement isn't always the hang-up, but it's obviously an important one.
Great. Thank you, Gary. Okay, I like the fact that we're down to a suitcase-sized answer to telemedicine, but we're all familiar with smartphones and mobile iPads. Why can't we use those devices and work on software to encrypt and make those readily available devices work for telemedicine?
Well, you can.
Right.
Yeah, so, it can be done. The other thing is it doesn't have to be encrypted. All health providers have to follow HIPAA, dealing with privacy and security of patient information. But the patient always gets to choose what level of security and privacy they want, and many will choose Skype or FaceTime or other things like that may technically not meet the gold standard of HIPAA, of being encrypted from end to end, but they choose it because the price is right and it's something that they're used to.
So yeah, I'd like to just add to that. That's a great comment, Gary, and you're absolutely right that the technologies are just getting better and more portable, and it is just a matter of encrypting and making sure that they're HIPAA compliant. So it's definitely in the horizon.
Okay, we have a few more questions, and if we can't get to everything today, if we don't get to all the questions, we'll try to address them in a follow-up email. You can certainly email the presenter. Let me see. One here. Allie, I think this is for you. Do you have an internal user champion to help with getting the rest of the team to adopt the telemedicine technology? What lessons have you learned from that, and how to go about getting that user champion?
We don't yet have an official telemedicine coordinator or user champion, but what we've actually tried to tap into is our neurology group. The lead physician in the neurology group, who's been doing telestroke for many years, has actually taken on somewhat of a role of leading the way and sharing information and trying to help us get other physicians on board. So I would definitely recommend it, though, based on some of the things I said in my presentation. It would be really helpful to have a coordinator to help the initiatives and help bring the different clinical groups on board. But right now it's been, an effort between IT and the administrative staff and the specific medical departments that have been filling in. But the goal is definitely to bring somebody on board to help coordinate that. I think it is a good idea.
Okay, great. And looks like one more question for you, Allie, is do you have any cases now or plan to use telemedicine to manage chronic disease patients? What are you doing in that area?
Yes. So we actually have a couple pilots that are either ongoing or just getting started, more along the lines of just using sort of a video conferencing solution, but we have our PD endocrinology group that is trying to do video consults with their patients for diabetes management. That's one use case, and another would be they're looking to start managing chronic liver failure patients with just some of their appointments and check-ins over video conferencing. So those are just a couple specific examples, but there are definitely lots of physicians coming in with, hey, I want to try telemedicine for these types of patients. So it's definitely growing quickly.
If I may add, I think that's another great question. We've thought about telemedicine as simply a way to connect subspecialists with patients, but there's a huge shortage of primary care. And there are lots of ways to try to address that solution, but one of the solutions can really be through telemedicine. Being able to link in residents and general medicine fellows with patients so that it's part of medical education is one possibility. But there are efforts. I talked briefly about the diabetes services, which is, although recently the CDC found is decreasing, is really incredibly prevalent in our country. So telemedicine can be a great service there. And there are efforts in cardiology clinics, again, with the whole concept of bringing in the primary service of the primary clinical care, but also these other adjunct services that may not be present locally.
Excellent. Thank you, Dr. Lopez and Allie. Okay, we are out of time. It's now 2 o'clock. I know quite a few people are still on the phone, so we appreciate you staying on and glad that you could join us to the end. If you have any more questions, I've got the contact information up here for each of our presenters. Feel free to reach out to them directly or reach back out to AMD Global Telemedicine. I can connect you with each of these presenters as well. We will be sending out a link of this presentation, which has been recorded, so you can watch it again or share it with colleagues that might have missed it that wanted to attend. Thank you for your time. Have a good day.
Thank you.